So we are starting our today's session, and we will be doing, hopefully, inshallah, two station, one of clinical consultation and one of clinical communication. So with this, we are starting our session. Bismillahir Rahmanir Rahim. And Dr. Ada, I am sharing with you the screen. And if you are able to see it and if it is quite clear, do let me know. Okay? Dr. Ada, please keep your mic unmuted. Then it will be disturbance in our
Okay.
communication. Please keep the mic unmuted. Because I am going towards the screen, then it will not be possible to unmute you again. Okay. So this is the case. My screen is clear to you?
Yes, I can see the
Are you
screen.
able to read it clearly?
Yes, I can read it.
Amazing. So please prepare your case.
Okay.
Dr. Ada, are you ready?
Yes, I am.
Amazing.
Okay.
So I am giving you your timer, and you have a total of 15 minutes with your patient.
Okay.
And you have to take the medical history, do the examination, address the concerns, and explain management plan to your patient. And if you're asking me for any clinical signs, I will share with you. Okay,
Okay.
good. So I am giving you the timer, and your time starts now.
Okay. Hello. My name is Dr. Adam, one of the doctors in the clinic today. Am I talking to Mr. Za, 40 years?
Yes, I am the same.
Okay. Well, we are here today to discuss about your medical condition. I learned you've been having this cough and throwing up blood. So can you tell me more about that?
Yes, what I mean to say is that I am suffering. And this
Okay.
condition is gradually worsening out. I am having cough, and this cough is really nagging. And also, this cough is associated with some coughing up of blood.
Well, I'm sure this must be very distressing for you. I'm sorry to get you're undergoing all this. So, before I continue, I just want you to know that whatever we discuss here is going to be kept confidential. So, this cough and this throwing up of blood, can you tell me exactly when it started?
It started now almost for the last 3 or 4 months.
Okay. So, and the cough, um, um, is it getting worse?
Yeah, it is getting worse now.
Okay, and the throwing up of blood as well.
Yes.
Okay, can you estimate it, like how much blood you kind of you throw up each episode?
Like it is a fresh blood and it is not happening all the time. I think I
Okay,
have got about 3 or 4 episodes of coughing up of blood in this duration.
okay. And is there anything you do that makes the cough worse?
No, nothing is making it worse.
Anything that makes it better?
No, I am trying some cough syrups over the counter one, but they are not helping me.
Okay. Any chest pain? Do you feel any pains in your chest?
Yes, you can say that I am having a chest discomfort also, or you can say it is low grade pain.
Okay, so when is it worse? Is it when you're taking deep breaths or when you cough?
You are a good doctor, and it is happening with this.
Okay, when you take deep breaths in or when you cough?
Yes, with the cough also, and also when I am taking deep breath in and out.
Okay, okay. And apart from this, any fever, any raised temperatures?
I am having fever also.
Okay. And can you tell me, is your body very hot or how do you feel?
Not very hot. When I am checking it, it is usually 100 degrees Fahrenheit.
Okay. Do you sweat a lot, especially at night?
Not much.
Okay. And well, this your cough from your notes that you've been treated for TB, tuberculosis, about 2 years ago. Can you tell me more about that?
Yes, I have been treated for TB, and also my mother was having TB. So, about 2 years back, I have been diagnosed, and yes, I was taking medications.
For how long did you take these medications?
Uh, I have taken, I think, just 3 months
Only 3 months. Okay. So is there any reason why you stopped taking these medications?
because of some side effects. I was
What
terrified.
what kind of side effects were you having?
I was feeling that I am having numbness of the hand and feet.
Okay.
Also, I was feeling weaker inside. Then I completed for the 3 months. Then in between, I was taking, but I will confess that I was not taking it regularly.
Okay. So apart from the numbness of the hands and feet, any other thing again?
Uh, Sorry, please ask again.
Did you experience any other
No, no,
symptoms again apart from the numbness?
no.
Okay. Okay. So okay. So Going back to what we were discussing, any weight changes?
I am having also some weight changes.
Okay. Is it were you gaining weight or you were losing the weight?
I'm losing some weight.
Okay, can you tell me how much weight you've lost?
I have lost about, I think, 2 kilograms of weight or 1.5 to 2 kilograms of weight over 4 months.
Okay, about 4 months. Okay. Is this intentional or unintentional?
It is totally unintentional.
Okay. And how's the appetite been? Has it been good?
Appetite is normal.
Okay, appetite has been normal. Okay. And what about what kind of job do you do?
I am working as a businessman.
Okay. And do you travel a lot?
Of course, I'm traveling a lot.
So when was the last time you traveled?
Last time I traveled, if I'm not wrong, about 3.5 months back.
3.5 months back. Okay. So when you traveled, did you come in contact with any sick people? Or anybody that was sick?
I don't remember exactly.
Anybody coughing?
I think, but I'm not very sure.
Okay. Any farm animals?
Of course, I was coming around various animals, and I was also visiting some lakes and some landscapes like that.
Okay. Do you keep any pets at home?
Ah, yes, I am having Persian kittens.
Pardon? Sorry, I didn't get what you said.
Persian kittens.
Okay, Persian kittens. Okay. And whenever you said you're a businessman, so you've never kind of worked in any shipping um yard or anything or gone to visit or have you have any experience with that?
No,
Okay. Okay, so any problems with your ball works?
uh, no, I don't think so.
Okay, what about your water work?
Waterworks, what do you want to ask?
Okay, any blood in your water works?
It happened. It
Okay.
happened twice.
Okay. Happened twice. Can you describe it? How did it look like? Was it
It was,
totally
I think, mixed with my urine. Like my urine was of the reddish color.
okay? Because when you take these drugs for the TB, it colors your urine. Is it the same or is different?
No, I will not correlate it with the TB medication because I stopped then about 1.5 year back. And this episode, rather these episodes happened about 4 months back.
Okay, about 4 months back again. So any do you notice that the water works the volume has reduced?
Yes. Also,
Okay.
I have noted it that it is now reduced.
Okay. Any frothiness of the urine?
Yes, it is also happening. I don't know. It is like a slime, something like that.
Okay, like a slime. Okay. And any lumps and bumps anywhere?
No lumps, no bumps.
Okay. So and do you kind of have any apart from this um TB, any long-standing condition you want to tell me about?
Mm, no.
Okay. And during your travels, I ask this to all my patients, so don't get offended.
Mm-hmm.
Um, do you kind of have maybe see other people or have more than one partner?
No, I'm just married. I'm not having any extramarital affairs.
Okay, I still ask this to all my patients. Do you use any illicit drugs?
No.
Okay. And what about have you ever smoked?
Yes, I'm a smoker.
Okay, like how many sticks of cigarettes do you smoke in a day?
I'm smoking more than about, I think, 6 or 7 sticks per day, and I'm doing it for last about 3 years.
Okay, try it. Okay. Then what about alcohol? Do you smoke do you drink alcohol?
No,
Okay. And so how has this affected your job and your home life?
I think I'm devastated. I'm not able to carry out my daily activities and I'm having fatigue a lot. Like if you're saying to me that go out and have some work, some office job regarding my business, I'm even unable to work more than 1 hour on the laptop.
And I'm sorry to hear this. More questions. Did anybody tell you that you look more paler than
No,
okay, any racing pacing of your heart?
no,
Okay, whenever you do you feel dizzy?
no.
Whenever you want to stand from a sitting position? Okay.
At least
Well,
I have not noted, yes.
okay, so I would like to examine him now.
For sure you can.
Okay. First of all, I want to do a quick general examination.
What exactly do you want to see?
I want to look at him, the weight loss you talked about. How is he looking? Is he looking cachectic? I want to
He is in front of you.
okay. So I'll look at the hands. I'll look at
You
any
are looking for the hands of the patient, and the hands of the patient looks normal to you.
okay. So then I want to go up, I'll check for pallor.
You are checking for the pallor, and the pallor is slightly evident.
Okay. And no cyanosis. I want to check for lymph nodes, any lymphadenopathy.
Exactly where you are checking for it.
I want to check at the cervical. First of all, I want to check at the submandibular sub. Um,
So you are
this
checking for
the
the neck lymphadenopathy. You
yes.
are looking, you are standing behind the patient, slightly extending the patient neck, and you are palpating for the lymph nodes, and you are checking all the groups, and you are unable to find a single lymph node.
Okay, so I want to examine the chest now.
So you are checking the chest now, and what do you want to check?
I'll check at the trachea. Is it deviated or is central?
You are checking the trachea and you are comparing the distance between the trachea and two sternocleidomastoid. And trachea is slightly deviated to right side.
To the right side. Okay.
Very slight deviation.
Okay. So chest expansion,
You
is this
are
still
left with 2 minutes from now.
okay? Chest expansion. I'll quickly want to listen to the just do a vocal resonance and listen to the breath sounds.
You are asking the patient to take deep breath in and out, and you are not touching your thumb on the patient chest wall, and you are letting the chest move freely bilaterally, and bilaterally the chest expansion is almost equal. Now you're
Okay.
auscultating the chest and you are starting from the behind and you are auscultating the all areas.
Okay. And is it normal?
Of course, it will take some time in the exam, so we are mimicking that time.
So I want to quickly do check for organomegaly. Does he have any organomegaly? Any liver? The
So your
spleen?
chest examination is completed and there are scattered coarse crepitations in the basis with scattered bronchial breathing.
Okay. So I want to check I'll ask him to cough if it's will clear.
So he is coughing. So what do you want to check?
Is it getting better? Is it clearing up or is still there?
No, they will change the character if they are coarse capitation. They will not
Okay,
improve or decrease. So they are changing the character.
okay. So I want to do a check for organomegaly. Any organomegaly, any hepatomegaly, splenomegaly, or the kidneys,
You are
ballot.
starting from the right iliac fossa and you are trying to feel the liver edge with your radial border of right index finger and you are dipping in your hand in expiration and you are keeping it steady in inspiration and you are moving ahead in each respiratory cycle toward the right costal margin and you are reaching up till there but you are not finding any liver edge. Do you want to check for spleen?
Yes, spleen and the kidneys as well.
So you are going ahead towards spleen and you are again starting the right iliac fossa and you are using again your radial border of the right index finger and you are gradually going ahead and while seeing the patient face and you are checking for the spleen and you are reaching till left costal margin and you are unable to find the spleen. Now you
And
are doing the palpation for the kidneys. How you will check the kidneys? Sorry, kidneys.
okay, I'll check. They're palpable, and I'll ballot for them. One hand under the patient,
So you
my
are doing the ballotment of the kidneys,
yes,
and
yes,
your concept is that you are putting your one hand at the
my
back,
right
the left
hand
one,
underneath, and my left hand, or my
and with the
left one
right
underneath, and my
hand you
yes,
are pushing down the kidney, and you are expecting it to float in the peritoneal cavity and touch your left hand like a ball
yes.
and you are doing it bilaterally and you are unable to allot the kidneys and your time is up.
So
Okay, you have to give me a second, please. So, Dr. Ada, we need a very crisp, good, mature summary of your case, only positive findings.
okay, well, I examined this 40-year-old man who came in with a 3 to 4 month history of cough with recurrent hemoptysis and with a positive history of weight loss and as well well with pleuritic chest pains with low grade fever. He had the past treatment of pulmonary tuberculosis, he which was poorly treated. He never completed his treatment after 3 months due to side effects of one of the medication. So
Mm-hmm,
on examination, the only positive findings I could get was that he had a trachea that was slightly deviated to the right with
mm-hmm,
bibasal quas crepitations with bronchial breathing. So
mm-hmm,
summing all this together, I want to suggest that he has likely a disseminated tuberculosis, likely to the chest and to the abdomen, because he had some renal involvement with the hematuria, reduction in urinary output, and as well protein and urine.
mm-hmm,
Disseminated TB likely due to from a relapse due to poorly treated tuberculosis. And
mm-hmm,
also another differentials I want to put again is allergic bronchopulmonary aspergillosis, but it will account for the renal involvements. And the next thing again I want to think about is probably a systemic disease that could capture both the lung and the kidneys is amyloidosis.
mm-hmm,
Amyloidosis could have amyloidosis to the chest and to the
mm-hmm,
kidneys.
mm-hmm.
Want to
If
investigate.
this is disseminated tuberculosis,
Yes.
what is the evidence and how you will explain these findings of the lower chest?
Okay.
Also, if you are considering it as a case of disseminated tuberculosis, do you think that the weight loss of about 1.5 to 2 kilograms of weight over 4 to 5 months is enough?
Okay. Well, the weight loss, I would have inquired about his previous weight. 1.5 to 2 kg might not be very, very significant, but well, he had some treatment for TB, so probably he had some um at least he has had some treatment with the intensive phase for 2 months. So well, maybe we'll
Is there
just
any bleeding site other than these two bleeding sites?
okay, apart from the chest and the kidneys, he doesn't have any other bleeding sites again.
Are you asking categorically about other bleeding sites?
No, I didn't ask about the other bleeding sign.
Okay. Are you asking about systemic involvement, like fatigue? Are you exploring it? Are you exploring about the joint pains or the body aches? Whether this patient is having any joint involvement or not.
Okay, I didn't ask about his joint involvement, or I didn't explore about the fatigue. But I felt that probably he was pale. He had some conjunctival pallor. Could explain some of the fatigue he was having.
This patient is having some sort of what you are saying, the signs of CKD. Is categorically complaining you that even I am having foam and slime and the waterworks are decreased.
Mhm.
Are you able to think any other possibility in this regard?
Yeah, he could have a glomerulonephritis, if possible, because well,
If
TB
you
can
are
cause
thinking about glomerulonephritis, which sort of glomerulonephritis you are thinking in this context?
it will be more of membranous glomerulonephritis.
Is there anything which is involving both systems over there in this patient, except
Well,
TB?
okay, I talked about amyloidosis. Renal amyloidosis too could be
What
another
should
cause
be
of
the cause of amyloidosis in this patient?
a systemic disease. Like any systemic disease can actually cause amyloidosis. Infections or long-standing systemic conditions can result in
If we are
amyloidosis.
thinking about this patient, is there any cause of amyloidosis we are getting in this patient?
Well, I felt that probably his long-standing unpoorly treated TB could maybe may result in that.
How you will thoroughly investigate this patient?
Okay, first of all, I want to do his food blood count. I'll be looking at for his PACES volume. I want to look at the WBC count. I'm looking for any signs of infection, viral, bacterial, or even fungal infection. I want to look at the platelet counts. Look at since he's actually bleeding. I want to go forward to do my my EU creatinine, doing a kidney function to look at any derangement, any elevations in the creatinine or the urea, and look at other electrolytes like the potassium. I want to do a urinalysis, which will further confirm if there are any hematuria, proteinuria, and probably any other substance to suggest an infection. Also, I want to do a urine microscopy, looking at the morphology of the red blood cells. I want to go on to do an ultrasound. I want to do an abdominal
What do you
ultrasound.
want to see again? Explain what do you want to see in the urine detailed report or urine microscope?
Okay, in the microscopy, it will tell me the red blood cell. It will tell me if it's coming from the glomerulus or from definitely if it's coming from the kidneys. I expect to find probably it will be deformed, maybe fragmented. Then that coming
Mm-hmm.
lower down might still be intact. I want to look
Mm-hmm.
at for any cast, any glomerular cast. I want to look for probably any muddy brown cast. Maybe tell me maybe an acute interstitial nephritis, something acute.
Mm-hmm.
Okay, I want to moving
Mm-hmm.
forward. I want to equally um do my image. Before that, I want to do my blood test. I'm looking at for my Congo red
Mm-hmm.
if I'm actually thinking about amyloidosis. I want to do my imaging. I want to look
So
at the
you are doing Congo red stain, right?
yes.
Where from where you will get this tissue or where do you apply that Congo red stain?
Okay, well, I can take it from the abdomen, or
Mm-hmm.
abdominal tissue. And
Mm-hmm.
okay, I want to do my imaging. I'll do my abdominal ultrasound scan. I'm looking at the kidneys. I
Mm-hmm.
want to look at for any organomegaly, which we couldn't get on abdominal examination. And as well, I want
Which
to
sort
look
of
for,
organomegaly you are expecting in this patient except kidneys?
you can have a hepatomegaly.
Mm-hmm. Okay.
Okay, from the chest X-ray, he has told me that he has bilateral hazy opacities. I want to moving forward. I want to do a chest CT scan, which will further characterize my findings and looking at other findings or other details. And I want to equally do looking at probably just having other routine tests, maybe looking at the sugars, and I think those are the investigations I want to
Okay.
do.
So how you will make a thorough management plan for your patient? And
Okay,
say, for example, you're all complete TB workup is coming out to be negative now.
okay. If my TB test is negative, okay. If my TB test, it depends on my findings on other examinations. Okay, looking at for any kidney dysfunction, and also since he has a fever, looking at cultures, doing a blood or urine cultures, if there's any signs of infection.
I
And
don't
so,
believe that this infection will be going on and on, except the chronic infection for the last 4 years, 4 months. At least this is not something acute.
okay. So depending on the investigations, so I'll manage him depending on my investigation findings. So if I get probably from the chest findings, it has bilateral class crepitations. Bilaterally, I want to. There are so many things that could result in having bilateral class crepitations, um, ranging from since we are excluding an infection, it could be probably even I think exclude any connective tissue disorder because he's a young person. That
Okay,
could
okay, no, Dr. Adar, you are going far away from diagnosis, and I will explain to you exactly what went wrong in this scenario and how to appropriately approach this case. Okay,
okay.
Dr. Adar, you are making some mistakes in this scenario, and various aspects of the history are not covered, and also we are missing examination. Okay, first thing in the PACES, what exactly required in the PACES is that you must not make your mind. If you are making your mind toward a particular disease because this patient is having pulmonary tuberculosis and has been non-compliant with the ESR of 80, and I'm considering it as a TB, this is a good approach. You should think about TB and you should think about reoccurrence or dissemination of the tuberculosis, but we will not fix our mind towards one possibility. It is very important to keep your mind open and explore the scenario and digest each positive finding which you are getting in the case. We are getting multiple positive things in this case, and it is very important to correlate each and every. As we are starting our case, we are knowing that this is a middle-aged man and he presented to us with the cough and recurrent hemoptysis. So we are starting with the OG para. In the OG para, we are getting that the cough is of gradual in onset with a duration of almost 4 months. As we are exploring that this cough is having no aggravating or relieving factor but is associated with coughing up of blood. This is the first mistake in the scenario, that you should ask exactly whether this cough is productive or not. This was the productive cough. Then coming to hemoptysis, we will be asking exactly that which sort of bleeding is that, and you are asking about the amount, whether it is mixed with the film or not, and how many times he is passing or coughing out of blood, and he is telling about 3 or 4 times. So what we are getting in this case up till now, that this patient is having some chronic problem and he is having cough with the coughing up of blood for the last 3 or 4 months. And these episodes of the cough are now getting worsen up. So we are stopping over there and we are thinking exactly what we are dealing with. Cough, the chronic one with coughing up of blood. If you are getting a clue, if some possibilities are coming in your mind, like bronchiectasis, say for example tuberculosis, say for example other causes of coughing up of blood like tumors, that's a good thing. If they are not coming in your mind and you are getting confused, just complete all the questions of pulmonology. So, what are the questions remaining in pulmonology? We will be asking about any wheezing, or of course, it will be ruling out COPD or asthma. I'm not saying completely ruling out, but of course, we will be getting it down the list. We are asking about the chest discomfort or chest pain, and you have done a very beautiful job over there that you're asking exactly when it is getting worse, and the patient is saying that it is with taking deep breath in. So one refined question should be that we should ask exactly what is the location of this chest pain. And if you're asking me, I would say that I am having chest pain bilaterally. So bilateral chest pain with taking deep breath in, likely because of pleurisy or something like that. So up till now, what we are getting the chest discomfort or the pain by taking deep breath in and out. And this is bilateral with the cough, which is projective, as well as coughing up of blood for about last 4 months of duration. Having said that, I am always teaching you people a scheme. It is must in the case of gastroenterology, in the case of pulmonology, in the case of nephrology, that if you are getting one bleeding, the next approach is to ask yourself, am I dealing with the local bleeding or this is something systemic? The question will be exactly, are you having bleeding from any other part of the body? Rather, the best question should be, ever you got any bleeding from any part of the body? So you are asking a journal open-ended question, and he is bound to now tell you that, yes, I got an episode of bleeding twice in the waterworks, and also I was having bleeding from my nose. It was fresh bleeding twice. Dr. Ada, are you with me?
Yes, I think I know the diagnosis.
Yes. So my voice is clear to you?
Yes, it's clear.
So what I am getting up till now, that my patient is having hemoptysis, my patient is having epistaxis, my patient is having hematuria. Having said that, I am sharing with you the picture of this patient. And it is very important to have a very good examination. I can appreciate this fact that the candidates are in stress and you are under catecholamine rush in the exam and you are sometimes confused, but your eyes should be very open. It is very important to seek and to look and to judge for the findings. Sometimes you have to look for them to gather a clue. If I am saying to you that and you're asking me any bleeding anywhere from any other part of the body, and I'm saying that I am having bleeding from the nose, it is a must for you to inspect the nose, or you have to at least look into that matter. So if you are seeing this patient closely, this patient is having some deformity on the nose. Can you appreciate it?
Yes,
Can you appreciate it? Follow my
I can.
marker.
I can.
So this is something which is relevant. This is something which is relevant. If you are getting it or if you are seeing it, that's a good thing. If you're not seeing it, no problem. Still, you have to examine the nose with apex taxis. So, if you are a keen observer and if you are keeping your eyes open, I would say that you should examine the nose like that. And you can follow my pointer that this is something which is important. PACES candidates should keep the eyes open. If you're not thinking about something or if you're not seeking any finding, it will be quite difficult for you to reach a diagnosis, providing that you are not looking for it. So we are always correlating the things. When we are getting a new thing in the scenario, it is very important that we should correlate it with the current symptoms. So what we are getting up till now, that my patient is having hemoptysis with the cuff, with some film production, and he is categorically telling me that I have got 2 episodes of apex taxes and 2 episodes of hematuria. So one thing over here is quite clear that I am not dealing with local lung pathology. This is something which is involving multiple systems. This is a multi-system involvement, and this is a clue to explore other things. So when you are getting it and you are taking a short history of apex taxes, how it happened and what was the amount of blood, and then you are coming towards renal system, sorry, the nephrology. In the nephrology, you are of course asking about the hematuria, and you are taking a good history of it. And you are even separating it from the orange discoloration of the urine because of ATT. But you're not getting it, and he is categorically saying that I am getting it about 4 months back. So this is a true hematuria, and the nice approach employed by you is that you are categorically then asking about CKD questions like decrease or increase in waterworks and slime or foam in waterworks. When you're touching this portion of nephrology, it is very important for you to even ask about periorbital puffiness, pedal edema, itching, and the signs of anemia. So in this way, you will complete your CKD clinical signs. It is very important to ask the following question. I'm again repeating: decrease or increase in waterworks, slime or foam there, and the patient will categorically be telling you that I am having this with pedal edema, periorbital puffiness, and the itching. So you have to ask this, and the patient will of course tell you. So I am again stepping back, and what I am getting, towards which direction my case is going. Number one, there is a renal involvement. Number two, there is pulmonological involvement with some nasal involvement. So we are ruling out different things, and we are keeping our pathway straightforward, and we are correlating exactly in which direction my case is going. Clear?
Yes,
Hello.
I can hear you.
Good. Now it's time to ask yourself what it can be. What is involving the both systems? If you're getting a clue, check stress syndrome, say for example, you are getting or gaining a clue of other syndromes, which are renopulmonary syndromes. That's a good thing. If you are not getting the clue like Wagner's, no problem, just follow your scheme, and your scheme states that it's the time to move towards general questions. So what are the general questions which we are always asking in all the cases, and it should be on our fingertips? So these questions are weight changes. That's a good question. It will also cover the weight loss as well as the weight gain. If the patient is having weight loss, we should ask exactly whether it is intentional or unintentional. Secondly, lumps and bumps, very critical question in this scenario, because maybe we are dealing with tuberculosis. Then we are asking about any rash, spots, or pigmentation. Rash, spots, or pigmentation. These are three different categories in the dermatological manifestations. It is very important to ask all three separately. Rash will not cover for the spots, and spots will not cover for the pigmentation. So if you're asking me, I would say you that yes, I am having something like that. So I will show you if I am saying that I'm having some discoloration or some pigmentation. So you should ask exactly, please show me now. This is the principle of your clinical consultation, that you should immediately see the finding. So you're getting some purpuras over there, and they are widespread, and you're not asking this question to me. Then after that, you are asking me about dizziness on standing from a sitting posture, weather preferences, the diet and the appetite. And in the general question, it is the must for us, and this is our daily routine in our courses, that we are never forgetting the two more questions, and we are always asking joint involvement and the fatigue. When you are asking, or rather, you're not asking, I'm saying you that I am having bad fatigue. So, what we are getting up till now, that this patient is having the involvement of the kidneys with the pulmonary involvement with the apex taxis, and I am getting some B symptoms like low grade fever. And when he is saying that I am having low grade fever, at least you should ask exactly when it is happening, evening, rise, or morning, continuous or intermittent. So if you're asking, I would say you that I am having low grade fever, it is usually in the night. I am getting in the general question following a positive finding that my patient is having low grade fever with purpuras, with fatigue, with slight weight loss, and the last thing I'm getting is joint involvement. I'm having pain in my joint. And if I'm saying that I am having pain, you should ask exactly the site of the joint pain. And if you're asking me, I would say you that this is my joint. Are you seeing it, Dr. Ada?
Yeah, I can say.
So what we are getting in this case, that this patient is also having arthritis, also having swollen joint, that is itis, inflammation is there. If this joint is quite inflamed, this is not a simple arthralgia, rather this is itis, arthritis. We are seeing the swollen joint, we are seeing the red joint, and we can see that it is obviously quite, you can say, enlarged. You can say that there's some accumulation of fluid in the joint cavity if we are comparing it from this joint. So also this finding you have missed. Now what we are doing, a good candidate will step back and he will take a break. He will ask him or herself exactly where I am heading, what I am getting. So we are getting the involvement of the lungs with the kidneys with some non-specific symptoms, that is weight loss slight about 1.5 to 2 kilograms over 4 to 5 months, with joint involvement, with purpuras, with the fatigue. And this is, at least one thing is very sure, that the case of vasculitis. This case which we are dealing is slightly a straightforward case because we are getting pulmonary and nephrology involvement, and this was a case of Wegener's granulomatosis. Of course, the other such syndromes will come in the differentials, like Goodpasture disease, like Churg stress syndrome, because they are of the one family. They all vasculitis are involving both lungs and the kidneys. But there is a critical question, because the vasculitis is sometimes easily missed by the PACES candidates in the exam. Why it is happening, and even not in the exam, it is a really a challenging sometimes in the real life, that you are missing vasculitis. Remember that if you are getting some B symptoms or some symptoms which are not directly linked with the disease, like you are getting slight weight loss, features of anemia, with the fevers, with the purpuras, and the joint pains, with the fatigue, the candidate must think of vasculitis. It is must. Again, I'm repeating for your comfort that the low grade fever, features of anemia, with the fatigue, with the fever, the low grades, why I'm mentioning weight loss, and the purpuras, these are the features of vasculitis. The next job will be, of course, to explore exactly what we are getting in vasculitis. Dr. Ada, everything is clear?
Yes, everything's there.
So one mic is unmuted, so I am basically talking about all the listener out there. But of course, because the one mic is muted, so I'm communicating with Dr. Ada, and I will take up the questions in the end. Now, it is quite important for us to go towards the past history. The past history, one thing is very evident that my patient is having pulmonary TB. So you are taking good history that when it has been diagnosed, and of course which medications you are taking. You're not asking this, but you should ask it, and for how long you're taking it, and you're also exploring the cause of non-compliance. So this patient is taking TB medications only for 3 months, and after that, he was taking it intermittently. So you can say that this patient is a drug defaulter. So it's time to move towards any other past, you can say, medical condition he's suffering from, like asthma can be. It will be the clue to the Church stress syndrome. Or sometimes remember that these patients with vasculitis do have something called mononeuritis multiplexa. So you can get any one mononeuropathy and nerve involvement. So you should explore it. Now, having said that, we are asking about the allergies, and I am always teaching you people that the allergies are of critical importance, especially in our pulmonology. So you should be asking about any medication history, any any medication allergies, any food allergies, and also importantly, more important is pollen allergy, dust allergy, and all that things you have to ask. Then the medication history. Maybe we are dealing with some medication side effects. So in the medication history, it is very important to ask about or seek for the medication list. And then you have to ask about where you are you compliant with this list or not. Because if he is showing your medication list, there is no guarantee that he is taking them as prescribed. The third question should be, of course, that any other medication other than this list. And it has happened in the exams that the patient was taking the beta blocker of the wife, prescribed to the wife, and she was having some palpitation, something like that, and he is taking those medication, getting to exploration of asthma. So you should categorically be asking about any medication other than this list. So what are the question? I'm repeating again the current medication list. Second, are you compliant? Third, any other medication except this list, including over-the-counter preparations as well as the herbal preparations. And then you have to go towards any stoppage of any medication before the onset of these symptoms. Then any start of any medication before the onset of these symptoms. And then, of course, any side effects of any medication. This is at least a simple medication history to ask in each case. Family history is important, then the social history. Sajid loves tea. So, as for smoking, how many sticks per day and for how long, and especially in if you are dealing with any neoplasia, if you are dealing with specifically pulmonology, so past history of smoking is also very important. Alcohol, then the job, and previous jobs are sometimes very relevant that what exactly the patient was doing before that, and I'm happy that you are asking and you're thinking about that. Illicit drugs, and if he is taking an illicit drug, the next question should be with which route you are taking. And if he is taking through IV route, it is very critical to ask that whether you are doing any needle sharing or not. Then the traveling history. In the traveling history, we are bothered about the prophylaxis. Are you completing all the vaccination? Which sort of tour was that? And very beautifully, you're asking about any contact with the sick patients. And of course, the activities over there really matters a lot. Can you, Dr. Ada?
Yes, yes.
Now we are stepping back. What I am getting Apex Taxes 2 episodes. I'm getting chronic cough. I'm getting pleurisy. I am getting hemoptysis. I am getting shortness of breath. It is important and very critical to ask how much you can walk before getting short of breath. I am getting the signs of CKD as evident by foam and slime in waterworks. decrease in waterworks with the hematuria. I am getting features of anemia. I am getting arthritis. I am getting purpuras. I am getting bad fatigue, and the patient is complaining. I am unable to even work on the laptop. I am getting a slight weight loss of 2 kilograms over 4 or 5 months, as well as evening rise of fever. So things are very crystal clear in front of me that I am dealing with granulomatosis with polyangiitis. It is also called Wagner's granulomatosis. Down the list, I will be thinking about those things which are coming in its differential, like stress or Gold-Pasture syndrome. Down the list, a TB, that is a disseminated TB, is also making sense. Having said that the Wagner's is at the top, I am stepping back and thinking I am planning for my systemic inquiry, because the systemic inquiry right now in this clinical consultation with the time duration of only 15 minutes, in which you are supposed to complete your history in 9 to 10 minutes, is very critical. So we are not going blind in the systemic inquiry and asking all the questions pertinent to all the systems. So it is important to ask about your syndrome. So what I am missing, and I am dealing with a syndromic variety. So I am thinking head to toe. Yes, I am remembering something, that these patients are also having sometimes, sorry, scleritis or uveitis. Are you understanding? My voice is clear to you?
Yes, it's clear.
So I am asking about ever. Not now. Now he is not having any red eyes. He is saying to you that I'm having no eye problem. Ever, ever, ever mean also in the past. Ever you got any blurring of the vision with the redness or pain in the eyes. So you're a safe doctor and you are exploring the features of your syndrome. Then you are knowing it very well that these patients are not only having mononeuritis multiplexa, but also having peripheral neuropathy. So I am asking about numbness, tinglings, or weakness in any part of the body. Such a beautiful question it is. Numbness, tingling, or weakness anywhere. The patient is bound to tell me if he is having any mononeuritis multiplex, or say, for example, peripheral neuropathy, that I am having this, and this. Then now it's time to move towards your examination. And examination in this case is quite tricky. Why I'm saying that it is tricky? Because I am getting multiple symptoms in this case and I'm having less time. So I need to have a very targeted approach towards this case. Having said that, it doesn't mean that I am only thinking about Wagner's granulomatosis. I should also rule out other differentials. Dr. Adad, just give me a second, please. Somebody is having, I think, video on, so please close your videos because of your privacy. Just give me a second, please.
Skip this video. It's
Okay. Are you guys able to listen to me clearly?
Yes.
Dr. Ada, okay. So now we are about to discuss examination. I was saying that it will be quite tricky one, because I am getting multiple positive findings and also I need to rule out my differentials, that is stress or good pasture and the disseminated TB and something else. Say for example you are thinking about something disseminated. So now I will start gradually, and I am first, you can say, making my mind because the time is less and I have no time to waste in unnecessary examination. So, patient presented to me with the cough with the hemoptysis, so it will be a wise decision to start from the examination of the chest. So, in the examination of the chest, this is a wise decision to start from the inspection, and then I am starting from the tracheal deviation. The tracheal deviation, I'm saying to you that this patient is having tracheal deviation. The trachea is shifted towards the right side, and this is a normal finding, Dr. Ada. Okay, this is a normal finding. And the normal trachea is slightly, I was using the word critically, that word, that slight deviation. So if there is slight deviation on the trachea towards the right side, you should correlate it with the positive finding. If there are no positive finding having correlation with this deviation, this is a normal anatomical deviation. So trachea was slightly deviated towards the right side, and I am explaining to you people previously that the trachea is usually shifted in the cases of upper lobe pathologies. Now, then I am skipping the step of checking for expansion because the examination is quite lengthy. I am going directly towards auscultation, and I am getting scattered bronchial breathing with scattered coarse crepitations. Likely it is because of that pulmonary involvement with the hemorrhages. My voice is clear?
Yes, it's clear.
Good. Then what I am getting positively in this case, that is I am getting renal involvement. So I agree that you want to do and go ahead for the kidney allotment, go ahead. But I will suggest that before that, do deep palpation. Sometimes kidney allotment is difficult to perform and difficult to get. So the wise decision will be to do a deep palpation, the S-shaped fashion of the abdomen. Then of course do the kidney allotment. Having said that, uh, we are stepping back, and I am getting multiple findings, and I am having time constraints and my time is running and I am under stress. So what should be the scheme now? What I should do now? Because right now you people are in your home and you are very comfortable, but in the exam is a stressful condition. So I'm stepping back and I'm asking myself what I have to check now. If you're getting a clue, if you're getting a path, that's a good thing. If you're not getting a path, no problem. Think head to toe. But there should be reasoning, there should be logic, there should be any thought before starting any examination. Say for example you are putting or you are taking up the fundoscope, keep in mind that it will kill at least your 45 seconds. If you think that there will be any findings in the fundoscope, then go ahead, otherwise this will be a suicidal approach. So in this case, I'm stepping back and I am restarting my examination to reorganize myself if I am losing the case or if I am in stress. So logically, I will be going towards the eyes and I am showing light in the eye to check any signs of uveitis up till now, and I can offer vision testing. I am slightly coming down and I am seeing the nose, and there is nasal deformity. And I am confirming it by checking it laterally as well as in anterior, posterior, frontal view as well as a lateral view. So I am sharing with you that finding the saddle nose deformity, and you can see it over there that the nose is quite depressed. If there is any question or if there is any confusion, we will be thinking and we will be checking it in this side by side direction. So sometimes this view is very helpful, especially if you're dealing with the pages. So sometimes you're dealing with acromegaly and nasal deformities. Clear?
Yes, clear.
So I am coming down And I am checking for the lymph nodes because there's a query for tuberculosis. That's a good thing. I am coming down and I am checking for the lymph nodes. Coming more down and I am asking, do you have any purpuras anywhere else? Any rash there? So I am getting it and I am seeing it quite closely. Then it's time to move towards the joint involvement and I am seeing this joint. Now, this is very important. At least these steps should be followed when you are checking for any joint. So I'm always repeating again and again this narration that this is a look, feel, and move. So a candidate should look for any swelling. He or she should be looking for any redness, any deformity, any discharge, any skin changes. Feel for hotness, comparing both sides. Feel for fluctuations. Feel for swelling. Then you have to move the joint. In the movement, it is very important to take a proper consent, and then you are starting moving it because it can be painful if the patient is giving you consent. Then you have to go, and in between, if the patient is having the complaint or saying you are, so do not get panic and do not say that you have made a crime. Simply apologize. Nothing will happen. Nothing will happen. So in the movement, we are doing it or dividing it in two parts. One is the passive movement and the other is active movement. So in the passive movement, I am moving the joint. I'm doing the movement after supporting the knee with my one hand, and I am flexing and extending the knee. Then in the other side, in the second step, I am doing the active movement. After that, now we have completed our examination. It's time to offer the what you say investigations, and I am always teaching you people that we must think of etiology of our diagnosis. We must investigate the differential diagnosis. We should seek for the complications of our diagnosis, and of course the association should be sought for. So I am offering some investigation and I should have some reasoning to offer them. So CBC to look for anemia of chronic disease with the blood loss anemia, and I am offering peripheral film to differentiate different type of anemia, and of course total leukocyte count offered by you is accepted. Then ESR and CRP, we are expecting it to be on the upper side, and we are not taking it as tuberculosis only because ESR can be on the higher side in any chronic, active, or chronic inflammation. Now, we can offer TB testing to exclude the TB, sputum examination, sputum microscopy, and also it will clarify atypical cells and the pus cells. Yes, you can offer the other testing for the TB, like the cultures and the gene expert. After that, we are heading towards our specific investigations. We are looking ahead towards this case, and first of all, the baseline should be to offer a chest X-ray. We can categorically get some nodular formation, some fluffy infiltrate, and some evidence of pulmonary hemorrhage. Of course, the chest X-ray will not be very sufficient, so we can offer HRCT and we can get a typical findings over there. If you are getting or having any suspicion of any malignancy, or if you are having some suspicion that maybe I am dealing with some mass lesion which is hidden under this hemorrhage, so feel free to offer bronchoalveolar lavage, or you have to get the cells out. Dr. Ada, voice is clear to you all people?
Yes, it's clear.
Okay, then of course, after that, I am going towards the renal involvement, and I am seeking for renal function test, and I am also checking urine detailed report or microscopy as offered by you, and I am checking for creatinine clearance and all that stuff. Sometime if the disease is in question, or sometime if you are confusing it with some other differential, so you can also offer renal biopsy. Then there are some other specific investigation for this condition, that is P-ANCA, which is quite specific for MPO. Now, it is important. It is important to look for the anemia. Say, for example, if you're getting it and if it is not been explained, so you have to offer complete anemia workup also. Okay, so one thing I am missing and I'm remembering right now, that when you are checking or examining this patient, you should also examine the inside of nostril of the patient. Maybe you're getting some findings there, some vessels. This is very important, some dilatation there. Okay, now the management. The management, of course, we are always dividing it in three parts: non-pharmacological, pharmacological, and surgical. In the non-pharmacological, we are offering the patient support, the social support, the financial support. Having said that, if we are offering social support, who is taking care of him at home? Then, of course, this patient is having fatigue and he is unable to carry out the daily activities. So we need the help from not only occupational health physician, but also occupational health therapist to see how we can modify the environment. Then all these respiratory vaccinations will be very important. Triggers, you have to educate about the triggers. And it is quite important in this case that you have to take the consultation from the physiotherapy department also regarding the involvement of the joints, and see are they offering something in the acute state, or they wanted to settle it by hot compresses and the others, and they will go ahead for physiotherapy later on. If the patient is anemic, and especially this is blood loss anemia, so you will also correct it by dietary reference. Ultimate is the medication for this condition. So it depends upon the extent of disease, how much the disease is extended, and how many systems it is covering or involving. So usually we are starting treatment with corticosteroids and cyclophosphamide. So you have usually two options to induce the remission. One is corticosteroid, with either you are adding up immunosuppressant or you are adding up some monoclonal antibodies like rituximab. So you have the two options, this regime: corticosteroids and cyclophosphamide, or corticosteroids plus rituximab. So always you are managing these conditions, the autoimmune one, under two headings. One is the induction of remission, and other is the maintenance of remission. Once the disease is in control, what is meant by flare? The patient is having active bleeding, the patient is having active symptoms. So you have to control it at that time, and you have to start either corticosteroids plus cyclophosphamide, or corticosteroid with some any other monoclonal antibodies. Why I'm preferring cyclophosphamide? Because it is having more studies and more proven in this regard. So in the maintenance remission, you are again having some sort of immunosuppressants, and these immunosuppressants you can try multiple one, but usually two are well studied, that is azathioprine and methotrexate. So this is a straightforward management in which you are getting a flare, and you are managing that flare, and you are then maintaining the remission. Say, for example, if the patient is in the renal shutdown and they are having a criteria, if the creatinine is more than 500 micromole per mil, then or the patient is having extensive hemorrhage and it is not been controlled with cyclophosphamide, so it is also the indication for plasma exchange. So this is all about this case, and I hope that my narration and my explanation was quite clear to everybody.
Yes.
Clear?
Yes, clear.
Good. Just one thing I want to say, because of course at time we are having less time and we have to also do a clinical communication scenario. Maybe somebody is thinking about it, struck stress. Remember that the struck stress usually presents with the symptoms of anemia. And if the anemia, sorry, not anemia, sorry, asthma. So if the patient is having asthma, so of course drug stress should also come in the differential, and the asthma usually is with wheeze and there is diurnal variation. Then good posture syndrome can present in a similar fashion, but Church stress syndrome is never involving upper respiratory tract, as this patient is having this nasal involvement. Sometimes these patients can give you the history in your real life and also in the exam that they are having a recurrent flu-like symptoms. Basically, this is not a flu. This is a bleeding or the production of secretions which is accumulating in the sinuses, leading to recurrent sinusitis. So recurrent sinusitis sometimes can be the presenting complaint in these patients. Dr. Ada,
Yes.
are you ready for your clinical
Yeah,
communication?
I am ready.
Good. I'm so sorry, I'm missing one thing more, arthritis. And arthritis, we have managed it by hot compresses. We have managed it initially with the restriction of movement. We have managed it with later on physiotherapy, but along with the mainstay of treatment, that is corticosteroid plus cyclophosphamide or corticosteroid plus antibodies. So you can also add NSAIDs in this case. Okay, Dr. Ada, I hope you're ready for your next case.
Yes, I am ready.
This case is having complexities, having multiple legal issues and ethical consideration. Please read it
Consultation.
carefully, then we will be back.
Okay.
Prepare it in the 3 minutes.
Okay.
Dr. Ada, are you ready?
Just a minute.
Okay.
Okay, I'm ready.
Okay. Okay, Dr. Ada, I am giving you your timer, and your time starts now.
Okay, hello. My name is Dr. Ada. I'm one of the doctors in the clinic today. Am I talking to Mr. Assam?
Yes, I am the same.
Okay. Mr. Hassan, we are here to discuss about your father's condition. And I believe that he has discussed with you, and he believes that we should discuss about his medical issues.
My father is not speaking. He is totally not in senses. He is not talking to me for the last 5 or 6 hours.
Okay. Okay. Um, well, that's right. Before I proceed, I would like to understand what you know about what has been going on with your father.
Some fuss is going on in this hospital. I am really not satisfied with the care provided over there, and you people are not respecting the wishes. We are suffering as a family. My whole family is sitting outside. I am holding lasting power of attorney, and my dad is really critical. Suddenly, he lost a consciousness, and I am bringing him to hospital. And these people, your team, they were saying to me that they want to do some clot dissolving procedure, which has some risk. And this is very important. And I was saying them that go ahead, no issue. And then they were giving me some paper to read about the complication and all that stuff. And I was terrified. That is quite a risky procedure. It is being offered in very less hospitals around the globe. So I was saying no to that procedure, and I was saying to them that, of course, it is better that you should not perform it because my mom was having a similar episode of stroke and she has recovered fully. Take my word, she was totally unconscious, and now I'm listening a new story that something bad has happened, and I'm really terrified what you have done to my dad.
Okay, well, you are right, and your concerns are actually very valid, and before I actually proceed, I just want to ask, you made mention that your mom had similar condition.
Yes,
If
of
I'm right,
course.
okay. And can you just tell me more about that?
She was having stroke and she fully recovered.
Okay. Okay. So in your dad's case, it's almost a similar condition. He had a stroke, and from everything, the when you have a stroke, there are ways we can treat the stroke. And I think you've been discussed, or they told you about what the brain scan actually revealed.
They have drawn multiple diagrams for me on the paper and I know it very well.
Okay. Okay, yeah, well, that describes what we're actually talking about. So from what it was, the strokes, there are two ways you can actually treat it, and the way that was discussed with you was giving him um a a, a clot lysing chemical that would lyse one of the clots in the brain and kind of free up the vessels that were clogged
Mhm,
in it and causing him to have those areas of the brain that were not supplied by the were not supplied blood. So, and it
mhm,
actually has a very short time where you need to give those that chemical so that the brain doesn't die. So, and
mhm,
when your dad was he was assessed, he was within that golden period, and that's why the procedure it was looked at. We had various ways to assess him, and it was looked at, and it was felt that he would benefit from it. And looking at it was a life-saving procedure for him, so
mhm,
for his brain. So we decided that we could proceed with
mhm,
giving him that chemical. But of course,
mhm,
with every procedure, there are always side effects. And
mhm,
one of the major side effects that we're afraid about is the bleeding, which
mhm,
happened in his own case. So I don't know if I'm
mhm.
making any sense here.
So what you're talking about now? What has happened to my dad? Please say to me clearly, because I am suffering from it, and all your narration, your talk for the last 5 or 6 hours.
Okay. So what I'm trying to say is that your dad had the side effects. He bled into the brain because of the procedure we actually tried to save his brain from.
So what now?
Okay, so what now?
So what are the chances that he can recover from this complication?
Okay, so well um the problem is that what I'm trying to say is that I don't really have any good news for you right now.
Mm-hmm.
And the chances that from him recovering are actually very slim.
Mm-hmm.
And he may not recover.
When I am saying to you that I am holding lasting power of attorney, and I am taking all the responsibility to write down all the papers, Lama, Dama, and all that stuff. Why you people are going ahead with this risky procedure? I was taking responsibility at the lasting power of attorney and having holding next of kin status. Who will be responsible now?
Okay, I understand. I understand you are very upset, and I I know that you've actually been told about this before, and well, what happens is that when we have a life-saving procedure that we believe that the patient can benefit from, so most times the medical decision kind of like is being looked at as priority, in this patient for the patient. So in your father's case, that's what happened. Looking at
And you
him next.
have provided the benefit by causing the complication by your non-competent hands. I was ready. I was ready to sign all the papers and I was taking responsibility. And I am again and again and telling this narration to everybody and shouting there that I am having lasting power of attorney. Now,
Yeah,
who will be responsible?
okay, I understand. I understand your pains. I understand you have the legal authority over your father's health. But what I'm trying to say is that when we have such situations, and when there's a decision for us to save a patient, um, in terms of an emergency like this, and such decisions to save the patient actually comes priority over any other legal documents. So in your father's case, to take him for the procedure which he had, the thrombolysis which he had, actually supersedes in the decision which was taken at the moment. But what happened next was the side effects that, well, it's a side effect that happens, and nobody predicts who will have those side effects. But so those are the major complications which happened here. So we can't predict who is going to develop the side effects and who will not. So, and in your
What
father's
are
case,
your future plans for my dad? I'm really worried and I am not in a good hospital.
okay, well, I'm sorry you feel this way, because we try to give your dad as the best management as we can. And what I still don't have any good news for you, because it has been decided that he is a patient that um we are not going to resuscitate. So
What do you
if any
mean by resuscitation? You are left
okay,
with
if
2 minutes from now.
so if anything kind of happens to him, he has maybe his heart stopped beating, we are not going to intervene. So
Why?
those are
Why you are saying so?
because
Why you will not intervene?
okay, well I still I'm still sorry to say that what has happened is that the bleeding he has had in his brain, we really can't intervene to do anything much for him. So we've looked at the benefits of bringing him back, and looking at the what is going to be his quality of life, trying to save him. So, and it's been found that for his benefits, we may not need to kind of give him any further any life-saving procedure again.
Really, this is quite terrible. And you people are basically saying that you people will not give any chest massage to my dad.
Well, I'm
And you
sorry to
people
say
will
that.
not attempt to save him.
Yeah, I'm sorry that is what is going to happen.
You
Um,
can give him a chance to live at least once. And if you people can't do that, I can even arrange air ambulance and I can bring him anywhere around the globe. I can sign the Lama or Dharma paper for you.
I understand your concerns, and I know that well, you're acting in the best interest of your dad, but at this point in time, trying to intervene, in this situation won't be beneficial for him, because looking at the outcome, what is going to be his long term, or what is going to his quality of life afterwards, will not be it will not be of his interest. So that's why we've
Time
decided.
is up. Okay, Dr. Atta. And this case is quite a critical one, which is testing the candidate's knowledge about multiple aspects. At one point, this case is testing your knowledge, how well you are in breaking bad news. Number two, it is testing your legal knowledge about the lasting power of attorney, the next of kin, and advance or directives. This case is also testing your knowledge about DNAR status. So first of all, I will explain to you about these legalities, legal issues, and then we will be repeating this scenario and let's see how we can do it very well and refine it. Overall, your approach was fine. Overall, you had a good grip on these points, and overall, you are performing very well. Yes, you were running out of time, so the tip is that you should use small sentences and try to speak in the points so that you should save time. Clear?
Yes.
So before I go ahead, there are few important points and I need the attention of all of you before we are unfolding this case. Number one, remember that the lasting power of attorney is a person who has been designed or sorry given the status by the patient that if I am getting unconscious or if I am losing the capacity, then he or she will be able to make the decision about the patient health, wealth, and other legal things, and it is being done in a very legal way. So lasting power of attorney can make the decisions on the patient behalf if the patient is not having any capacity. What is the capacity? Capacity is a status in which the patient can understand or take up the information, can retain the information, and can make the decision about his health based on that information and can communicate this decision to the treating team. Again, I'm repeating what is capacity? Capacity is the ability of the patient to get or understand the information, then retain the information, then do a mental processing to make a decision about his health condition based on that information and communicate that decision to the treating team. If the patient is unconscious or under the influence of drugs or alcohol, of course, he cannot make that decision. So sometimes they are assigning somebody as a lasting power of attorney that if I am losing that capacity, somebody can make the decision on my behalf. Clear?
Yes.
Hello? Okay. Second is something which is advance directives. This is a written legal document that the patient is writing about the future, about the wishes, about the future plans. Say, for example, he's writing down under two evidence the lawyer that please never put me on hemodialysis or never put me on ventilator if I am losing the capacity. This is advanced directives. Next of kin is a person who is taking care of that person in the last days. Next of kin cannot be necessarily a lasting power of attorney. Say, for example, a patient is having five sons. He is living with one son who is taking care of him. So the next of kin will be that son. Maybe the dad is assigning the lasting power of attorney, the eldest son, so that son will be having lasting power of attorney. These are slightly complex and they seems to be complex, but originally or really they are not complex if you're understanding them exactly what RCP requires from you. So let's first start with lasting power of attorney. Remember this principle that lasting power of attorney cannot demand any medical treatment. Yes, he can bring the patient to the hospital and treating team will decide what is best for the patient. If the treating team has decided that it is very necessary to thrombolize this patient or perform any life-saving procedure, then the lasting power of attorney cannot deny that procedure or that treatment option. This principle should be very crystal clear in your mind that the lasting power of attorney cannot demand the treatment, and cannot refuse life-saving treatment. Next is the next of kin. Next of kin is a person who is with the patient in the last, you can say, days, so he can communicate you well about the patient wishes, about what the patient was wishing in the last days. Say, for example, my next of kin is my, I give you example, my younger brother. So he can communicate that Dr. Salman was saying that never put me on ventilator. Or say, for example, he's communicating you that Dr. Salman was saying never put me on hemodialysis. So now the next step is whether this narration is correct or not, whether this is truthful or not. So who will decide? Legal teams will decide, and we will forward this case to legal teams, because the patient is not having any advance written directives, and the next of kin is saying that please do not put him on ventilator because the patient was requesting it, so we will refer this case to legal team. You should keep it in mind. Why next of kin is important? Because the patient is having five sons, say for example. He is living with one son or one daughter. Other siblings cannot express well the patient wishes. The next of kin is a better representative of patient wishes. Having said that, now the things are quite crystal clear. Lasting power of attorney should be involved, or next of kin should be involved in any decision. I'm using the word involve. I'm not saying that take their consent. You are informing that we are going ahead towards, say, for example, thrombolysis in your that case, but we will not be requiring the consent. Why it is important or why it is critical? Because of course we need to talk with the family, or we need to communicate with one member from the family. The best person can be next of kin, or can be lasting power of attorney. Dr. Ada, everything is going smooth?
Yes.
Good. Now going ahead, and I am now decoding this case, and this case is testing you at various aspects of the legalities as well as the ethical considerations. So first thing is that you are opening up this scenario with your introduction, the patient's introduction, then of course establishing the rapport, setting the agenda, then applying the eyes. What I'm saying, hello sir, good morning. My name is Dr. S. I'm one of the doctor in the clinic today. Am I speaking with Mr. Hassan, the son of Mr. Naseem? Yes, I am. First thing is that you should confirm that we have already taken the permission of your dad to talk with you about his health condition. But you are making a very grave mistake over there, Dr. Adha. And this mistake will not only detect the marks of a candidate in the exam, but also give shatter your confidence during the exam. What you're saying that I have taken the permission, or I have you taken the permission of your dad, and the dad is not conscious. Okay, clear?
Yes, Glenn.
Hello. So
Yes.
we need to read the scenario very carefully and read between the lines, because everything is not written over there, everything is not crystal clear in the scenario. This is the extract, and you have to extract the meanings from this paragraph. So it was not necessary, it is not really logical to say that this, to suppose that the patient is conscious. First mistake, and this mistake will not only cut your marks, but also it will shatter your confidence in the very start. So the words matters a lot. Then you are saying, hello sir, I hope you're comfortable in this room, and I hope I am not keeping you waiting too long to see me. So as you are about to start with the ice, and what is the ice? I for idea, you are seeking the idea of the surrogate about the situation, like how much he is knowing about the situation, then the concerns of the surrogate, any specific concerns or expectations from this meeting, and then you are explaining the situation to the surrogate. You are surprised that he is really angry. He is not listening to you, and he is giving you idea at the start that I am knowing very well that you are going ahead with thrombolysis against my wish, and there is something fishy out there. Clear?
Yes, clear.
So be confident, because they are seeking your confidence, and they are seeing the art how you are handling the situation and how you are making it calm. Let him speak, and you are doing a very good job over there that you are letting him speak. After that, say that, sir, I appreciate your knowledge that you are well aware the condition of your dad, and I appreciate your concerns and the questions and all the queries. Your concerns are extremely valid, and if I am at your place, I would have a similar concerns or similar, you can say, questions in my mind. I am over here to satisfy all your queries, and I will explain to you whole situation, and we will talk in the end exactly how we can make it ease for your dad. Clear?
Yes, clear.
So you are saying, and you are now explaining all the legalities and the ethical consideration in your own words. And remember that three people are listening to you. Two are the examiners, and one is the surrogate. Okay? And things should be very crystal clear, and you should not speak in the code words. The things should be crystal clear. Sometimes there are three examiners and should not get terrified. The third examiner is the trainee examiner. Sometimes there are the four people in the room, three examiners and the one surrogate. So you are very confident, and you're explaining that, so your concerns are very valid. And I appreciate that you are having a good command on the situation, and you are knowing very well. I am over here to explain exactly what went around over there. So your dad, as you're explaining, was coming to us with the stroke. And now I will not go in the details. I will not explain all the things which he is already knowing, because he is categorically telling me that I am knowing it very well, what has happened, what is the stroke, and even the people, the doctors are drawing the diagrams for me. Okay?
Yes.
So I'm saving time. That I appreciate your knowledge that your dad is having stroke, and we were going ahead with clot dissolving techniques because he was having the blood clot in the blood channel of the brain, and it was being offered that it is a life-saving procedure, and if we are offering it in start of about couple of hours, it is improving the patient condition markedly. We were expecting that the blood flow will will be normal in the brain of your dad, but unfortunately we have there was a complication. As with the other procedure, this procedure is carrying the complication risk, although the risk is quite low. Your dad is having a massive bleeding in the brain, and he is sorry. Before that, stop. Breaking bad news. I'm so sorry, I'm skipping this step. After explaining that we are giving the clot dissolving injection, say that I don't have a good news now. So you have to say this twice. You have to give two warning shots. I am sorry, I am the one who is breaking bad news today. Okay?
Okay.
Two warning shots. So you are making a mind, and this is the ethics and this is the principle of breaking bad news, that you are always giving the two warning shots, and examiners are seeking for it from you. So two warning shots, that I don't have a good news today, and we were giving this lot dissolving injection, and your dad is having a massive bleeding in the brain, and he is quite critical now. Straightforward. Okay, because the time is less, because we have to save the time. We don't have the time to go around and around. So it's a critical situation. So now he will be shouting at you, or say, for example, he's arguing with you. So say very politely that this decision has been made in the best interest of the patient. This decision has been made to improve his condition, and we are giving this injection. This is very important according to local and international guidelines which are supporting it, and this injection is improving patient condition. It is very, very important to say local and international guidelines. You're not doing this decision on its own. This is not your choice. Even this is not a choice of a team. This is according to local international guidelines. Clear?
Clear.
So now he is arguing with you. I was saying to you that please don't do that. I was saying that it has the complication. Do not go ahead. I was ready to sign Dama or Lama paper. Say it very politely and gently that it is not about Lama or Dama. You are not authorized to sign the Lama or Dama paper because the patient can only sign it. Treating team has to act in the best interest of the patient to in especially in the life saving procedures. Clear?
Clear.
So you are very straightforward and you are saying it in very crystal clear way. Now the next task is that you have to explain about DNAR. DNAR or DNR is something called do not resuscitate status. Make it very crystal clear in your mind today that this decision is a decision of the treating team. How the treating team is making this decision considering the patient, of course, the comorbidities, the current situation, and the other associated situations. So, this is not a decision of a doctor. This is not a decision of, say, for example, the patient or the family. This is the decision of team. I'm again repeating, not a doctor, team. You cannot say that I'm deciding to keep her as DNAR or DNR, or I think that he will be DNR. No. In any scenario, you will not touch this topic. I'm again repeating, in any scenario, please do not touch this topic. I'm again repeating, in any scenario, even the advanced cancer, please do not touch this topic. If it is written, if it has been decided, then you will communicate because this is the team decision. This is not a decision of one doctor. Keep it in mind. Okay?
Okay.
Even the family cannot say that, please do not put him on the ventilator, do not give the chest compression. Yes, there are few situations they can communicate, next of kin can communicate that the dad was saying, please do not give me chest compression if I'm getting collapse. Now legal teams will assess its legality. Or the patient is having a written advance or directives signed by two evidence or lawyer, then you can consider that we will not give CPR to this patient. Clear?
Clear.
Otherwise, you will not make this decision. Treating team, whole team will make this decision. Now, how they're making this decision, multiple things are taken into consideration. In this situation, they are thinking that the patient is having advanced COPD and having massive hemorrhage, and there is no chances for recovery. So straight away, politely, gently, in a very professional way, communicate to your surrogate dad or the son that, sir, our team has decided to not make his suffering worsen. We are deciding to not give him any chest compression in case if he is collapsing. Clear?
Clear.
Now, of course, this is really not easy for him to digest this news, or this is not easy even for us. If somebody is, say, for example, talking like that, we can say, okay, go ahead, no problem. So you have to explain exactly. Of course, this is correct that this is a treating team decision, and the surrogate or the next of, sorry, LPA or the next of kin cannot demand it. But you are a communicator, you have to communicate that, sir, see, we are not linger on We are not trying to linger on his condition, his suffering. There are no chances for him to get a recover because this hemorrhage is quite severe and already he is having bad chest condition. Clear?
Clear.
This is a chronic condition with no recovery. So, if we are giving chest compression, and we are giving it to multiple patients daily in the hospital, in the cases where there is a chance of recovery, so we will give and we will be the advocate for that. But in your dad condition, these chest compression or these maneuvers will increase the suffering. Now there starts a bit of negative counseling. Okay, so it can lead to, of course, a rib fracture. It give immense pain to the patient, a discomfort to the patient, the last movements. The rib can rupture and even pierce the lung or the heart. So this process is very uncomfortable for the patient, and always we are taking the risk where there is the chances of recovery, and we do not want to make your dad suffer in the last movements. But yes, it is our promise to you that we will keep him comfortable, we will keep him quite, you can say, comfortable in the last time, and we are with you in this difficult time. And I can understand that these news are not really easy to digest. Clear?
Clear.
So it is very important because this is not only that you're going ahead and you're speaking in the paces and you're coming out and you are just like a robot or you are just like a computer, you are giving a lecture and coming out. Your tone of voice, the way you're communicating, the delivery of the words, the sympathy you are showing, the empathy you are exhibiting is carrying all the marks. Even your body language, the way you are sitting, the way you are making eye contacts are carrying the marks. And remember that examiners are very experienced and they are listening and observing your each movement. Now, this scenario will be based on just the communication by you. It is not followed by any viva. So the way you are playing in those 10 minutes, the way I am teaching you, the way I'm explaining to you, the way I'm telling you how to show empathy, that if I am in your position or your situation, it is very difficult. And I am with you, we are with you in difficult times because these news are not difficult to digest. It will carry extra marks. Okay?
Okay.
Good. Okay, so if you have the time, there is some time, or even last movements, offer some brochure, leaflets, web addresses to read more about this TPA and its complication, to read more about the DNAR process. Okay,
Okay.
good. So it is all about these two cases, and I have chosen these cases for you people because these two cases can teach you the approach of multiple other cases if you're grasping them quite, intelligently to clarify your concepts. So I will be dedicating 5 minutes for the question answer sessions. So if any candidate is having any question or queries, you people can use the raise hand option to come forward. Before we go ahead, Dr. Ada, do you have any questions?
Yeah, no, I don't have.
Okay, good. Zoom user, your name is not clear. Please unmute yourself if you have any questions.
So any role for social history here in this patient?
Social history should be asked in that case that how many dependents are there on your dad and how is the social support and the financial support of those dependents. But the thing is that you will not take the social history on the cost of ignoring the concepts or the points of DNAR as well as explain the complication. If you have time, touch it. If you don't have time, your empathy, your sympathy will show everything.
Okay, sir. Thank you.
Okay. Dr. Huda, please unmute.
Doctor, I want to understand the last power of attorney. He cannot take any decision for the patient, or only in the emergency. Yani, he can take a decision in another situation
You
except
have
the emergency.
to, yes, you have to involve lasting power of attorney or the next of kin in the situation. You have to explain to them, you have to take them on board, you have to discuss with them, you have to communicate with them. Because of course you need a person or family who is a patient representative to talk. But when there is any dispute, say for example, you are putting the patient on hemodialysis and he is not agreeing. Say for example, you're putting this patient on ventilator and he is not agreeing. So you have to say no. This is very crystal clear. You have to explain that the decisions are on the treating team and the treating team is always acting in the best interest of the patient and the LPA cannot deny it. I hope this is clear now. Any other questions or any queries? Feel free to use the raise hand option to come forward. Okay, if there are no more questions, and I am really thankful to all of you, Dr. Ada and the listeners, that you people have dedicated 2 hours to this session. Hopefully we will meet again. Thank you, enjoy your weekend, and good night.